Okay, good morning, everyone. Thank you, Ling, for the kind introduction. So I'd also like to thank the scientific committee for inviting me to speak at this meeting. So why is there a concern for chemical agent becoming a weapon for terrorism? Okay, as we are aware, terrorist attacks have evolved from the days of 9/11, where it's actually a very extensive, well-coordinated attacks involving thousands of casualties, to what we see today, having like maybe one or a few attackers shooting or driving a car into a crowded area. This caused much fewer casualties, but they also can lead to mass destructions and fears. So what is in store for us in the future? Can there be chemical attacks? Can terrorists use chemical weapons? Unfortunately, the answer is yes. So for today, we'll go through a bit of the history and see how chemical agents can be used as chemical warfares. And then we'll look at the different classes, how they are managed. And I'll end off the talk with a bit about the new advances in hazmat management. So going back in history. So the use of poison chemicals from plant extracts has been well documented in the Middle Ages and the Renaissance period. Okay, so the birth of chemical warfare is actually first in the World War I, when there was many casualties who died from poisoning from phosgene, mustard sulfate mustards, and also nerve agent. Okay, and in the 1980s, the Iraq actually launched a nerve gas attack and killed about more than 5,000 Kurdish civilians. So what is the evidence or what's the examples of recent use of chemical agent? I'm sure many of us will have heard about the VX after it was used to murder the North Korean Mr. Kim Jong-nam. And actually, a few days ago, it was reported on 4th April, there was actually use of chemical warfare, possibly nerve agent, in Syria. This has actually killed about 70 to 80 people, many of whom are children. So how can chemical agent be effectively dispersed to actually create mass poisoning and hysteria? So this one, okay, the first method is actually the most effective method. It will cause a large number of casualties, but it's actually will be quite uncommon. Okay, what is more commonly encountered would be the next one, where the chemical agent is aerosolized in explosion. So this picture is actually taken off the BBC website. It shows how the chemical agent is actually loaded into the rockets, and these rockets were actually fired during the Syria chemical attack in 2013, causing many deaths from nerve gas poisoning. The last method is actually a very simple method, but it can also cause quite a lot of problem. So this is just letting the chemical agent, because most chemical agents are liquid, it actually allows them to just evaporate. Okay, this is the method that the Japanese cult used in the Tokyo sarin attack in 1995. So what the cult member did was they actually bring bags of sarin into the subway, and before the cult members left the trains, they actually used the ends of umbrella to poke holes into the bag of sarin, and this allowed the sarin to evaporate and disperse the vapor. So this is actually not a high-tech method, but it actually killed about just 12 casualties. However, it caused 5,000 people to be actually poisoned with a nerve agent of varying severities. So this is how we can actually disperse a chemical agent. Next, how do we classify them? So it can be from various forms. The most common ways of classification is based on the physiological effects on human body. So chemical agent, lethal, and incapacitating. For the rest of my talk, I'll go through each class briefly to talk about how, what's their symptoms and how can we treat these casualties. So first and foremost, the more commonly encountered one or read about one is nerve agent. Again, this is a good illustration is the Tokyo sarin attack. This attack actually showed us how easily chemical weapons can be made, and a small amount of it actually can cause mass hysteria and poisoning. So nerve agent derived its name because it affects the nervous system. So how does it work? So the nerve agent will bind to the acetylcholine esterase, which is an enzyme that is required to break down the neurotransmitter called acetylcholine. So when this enzyme is inhibited, the neurotransmitters it will accumulate at the nerve junction, and the patients will actually manifest what we know as cholinergic tox syndrome. So what is cholinergic tox syndrome? This is similar to what we see for our organophosphate poisoned patient in the ER. This patient will be wet, so have lots of secretions, they are weak, they can seize, and they can die from the killer's bees, the bradycardia, bronchoria, and bronchospasm. Next, I'll talk a little bit about aging. So aging, this table shows the aging half-life of the various nerve agent. So when the nerve agent has aged, the bond that is formed between the nerve agent and the enzymes, acetylcholine esterase, becomes permanent. And when it has become a permanent bond, then the administration of the antidote oxim it becomes ineffective and useless. And in order to recover, the body actually have to regenerate the enzymes themselves, and this can take several weeks. So the teaching is always to administer the oxim as soon as possible. So moving on to the medical management, first and foremost, rescuer and staff safety. Again, I'll use the example of the Tokyo sarin attack. So when the attack first took place, the first wave of casualties, like any mass incident, would be the well-walking injured. So these casualties arrive on their own at the nearest A&E, that is nearest to the tube station, the train station. So what happened was they presented with symptoms of vomiting, diarrhea, feeling weak, a bit giddiness, pretty non-specific. So they were all treated like gastroenteritis cases or viral flu. And it was only a while later that one of the physicians realized, hey, this is not very right. These patient actually comes in with similar symptoms from the same place at about the same time, and that's when they suspect, could this be a possible chemical or hazmat incident? However, it's a bit late, so all the healthcare workers who were attending to these casualties were not protected. So some of them actually end up being victims of nerve gas poisoning themselves. Okay, so the next management for any hazmat incident is, after staff safety, is removal from the source. And next will be decontamination. Decontamination is very important. Actually, by removing clothes and showering these casualties, we can actually remove close to about 98% of the external contaminant. This is important because it prevents continual absorption of the chemicals into the body, and also it prevents downstream secondary contamination by healthcare workers and healthcare facilities. Next, resuscitation of ill cases will take place, and this is similar to any sick medical cases that we attend to, so airway, breathing, circulation. Of note, what is important in the management of nerve gas poisoning patient is the use of antidote. Atropine is very important. It should be given and repeated till the patients are dry. The lungs are dry. They show signs of that they are well atropinized. So what do you mean by well atropinized? It will be like dry lungs, good heart rate, and good BP. Oxim can be given to help regenerate the enzymes, but of note, PAM is not useful for certain nerve agents. Benzodiazepines can be given to abort the seizures. These antidotes are good because they are also available in the form of auto-injectors. They can be given in the field. So locally, we have this diagram to actually aid first responder to decide who needs antidote and how much to give. So this is what we call the 3Ds. If victims have 1D, that's dark vision, they get one auto-injector that contains PAM and atropine. If they are dark and drenched, 2Ds, then 2 auto-injectors. If they are dark, drenched, and disabled, seizing, coma, they get 3 auto-injectors with a diazepam auto-injectors. Okay? So the auto-injectors are useful because it can be applied over the clothing of the casualties, over the lateral aspect of the thigh. You don't have to strip the casualties. And more importantly, it's quite easy to use. So first responder wearing hazmat suits can actually easily apply these auto-injectors on the victims. So next, we'll move on to the blistering agent. As the name suggests, it actually causes signs and symptoms like burns. Okay. So if it's a dermal exposure, the casualties can have redness, blistering. If there's eye contact, there can be cornea, ulcers, and the patient actually can be blind. And if there is if vesicants is actually inhaled, they can also burn the airway. So again, about the treatment, it's like the nerve agent, rescuer safety. Decontamination is very important here because you want to limit the time that the vesicants can take effect on the skin. Okay. Of note, if the patients or the casualties comes from a blistering agent incident and they are well, we need to observe them for at least 8 hours, because the hallmark of any mustard exposure is that they actually are well initially, and the onset of pain and symptoms are delayed, so they get pain about 4 to 6 hours later. Okay? The only antidote that's available is for Lewisite, so the rest of the vesicants have no antidote. So maximum supportive treatment is the most important for this group. Okay, next we'll move on to choking agent. So two examples, well-known examples are chlorine and phosphagen. So casualties will present with what we know as irritant gas tox syndrome. Some of us in the audience may have treated casualties from the chlorine gas leak from the local swimming pool about 2005. So chlorine is a highly water-soluble agent, so it dissolves and irritates the mucous membrane. The casualty comes in complaining of coughing, pain in the eyes, tearing, and difficulty breathing or burning sensation in the throat. Whereas phosgene, it's slightly or it's less water-soluble, travels down further the airway, and it actually can cause lung collapse and non-cardiogenic APO. Again, coming to the management, for this group, oxygen and actually nebulization will help. And if they are well, they do need a period of observation because they can develop delayed non-cardiogenic pulmonary edema. Okay, next on blood agent. So one example is cyanide. So cyanide actually causes problem by inhibiting the Krebs cycle so that the body doesn't utilize oxygen effectively. So it actually binds to cytochrome oxidase and disrupt the electron transport chain. Cells goes into anaerobic metabolism. So tissues that are that depend a lot on aerobic respiration, such as the heart and the brain, will have problems. So at low dose, they actually cause giddiness and chest pain. High dose, they have seizures, arrhythmias, or collapse. Okay. So the management of cyanide poisoning, cyanide poisoning, again, rescuer safety, decontamination. Of note, there's actually good antidote for cyanide poisoning. So the nitrites and the thiosulfate actually displace cyanide from cytochrome oxidase. Hydroxycobalamin will bind with cyanide to form a cyanocobalamin, and then it will be excreted in the kidneys. Okay, lastly, incapacitating agent. So this is the agent that whose use has been dated back in the ancient times when actually anticholinergic alkaloids from plants were used to poison enemies. So in the military, for example, they actually tried LSD, which is a recreational drug. They give it to the soldiers, and they find that the soldiers are unable to cope. They cannot concentrate. They cannot follow commands. Other examples would be like BZAC. BZAC is actually a military warfare. It's incapacitating military warfare. It is very potent, about 25 times more potent than atropine. It's an anticholinergic. Ultra-potent opioids. One example is this is actually quite toxic. So patient can range from drowsiness to respiratory depression to coma. Many years back, when in the Moscow theater, where the theater goers were actually held hostages by the Chechen rebels, this was the chemical that the Russian army used to pipe into the theaterate to knock out the Chechen rebels to rescue the hostages. But in so doing, of course, there were some hostages that were also poisoned by the gas. Okay, in terms of management, of note, for BZAC toxicity, because it's anticholinergic, there's a high risk of hypothermia, so we need to manage the temperature appropriately and aggressively. If not, the patient can go into hypothermia-induced multi-organ failure, and they can die from it. Useful antidote for ultra-potent opioids is naloxone. It is available in the market in the IV form, auto-injector, and nasal forms. Okay, lastly, riot control agents known as tear gas. This causes temporary incapacitation because it irritates the eyes and the respiratory tract. It's actually quite safe unless it is given at large doses in an enclosed environment. Okay, so eye decontamination, and it is useful. Bronchodilators for people who are wheezing, and of course, the writers are quite clever. They do their own PPEs. Okay, to end off, what's next on the horizon? What is the new advances in hazmat management? Use of high-dose atropine auto-injectors, because we know that the aging of certain nerve agents are really fast, so by the time the first respondent or medical team reach the casualties, oxy may not be useful. So there have been talks about supplying troops with high-dose atropine auto-injectors to inject these patients. Okay, there will be newer antidotes, nerve agent antidotes, obidoxim, HI6. Again, I've already mentioned naloxone auto-injectors for ultra-potent opioid toxicity. And NAC is no longer, well, it's not only used in parasite overdose, it actually can be used to treat acute and chronic pulmonary complications from sulfur mustard poisoning, and it's been shown to be quite useful. So in summary, dispersal of chemical agent produces large amount of casualties in terms of the poisoning and the mass hysteria. Always ensure responder and staff safety. Decontamination is very important. Medical treatment is also important as there aren't many antidotes. Mainly, it will be supportive and symptomatic treatment. Okay. Thank you.